Good day, dear students. Today we will have a lecture on discipline Foundation of Endodontics. The theme of our lecture is Modern Approaches to Endodontic Treatment, General Characteristics, Main Steps, Concept of Working Length. The purpose of the lecture: to study the stages of endodontic treatment of teeth. Relevance: knowledge of the stages of endotherapy is necessary to provide high-quality dentistry. Help for patients with complicated caries. Their precise implementation allows to increase the efficiency of the assistance provided and reduce the likelihood of retreatment of teeth. Main objectives of root canal treatment. The first: removal of pulp putrid masses from the entire root canal system. Disinfection of the root canal. Three-dimensional obturation of the root canal system. Sealing the root system to prevent crown or root leakage. The success of endotreatment depends on diagnosis, knowledge of the topographic anatomy of the tooth cavity and root canal, surgical and medical treatment of the root canal, adequate root filling. In this picture we see a focus of inflammation, missed channel of the doctor, and caries in this tooth. Factors affecting the outcome of endodontic treatment. In all cases: topographic anatomy of the root canal, X-ray symptoms, destruction for X-ray film, the thoroughness of the surgical treatment of the root canal, aseptic mode of treatment, quality of root canal filling, the state of health of the patient, timelines and qualification of treatment control. Factors that affected the outcome of endotreatment. In selected cases: the state of the marginal periodontium, chewing load, the degree of obliteration of the root canal, the presence of resorption, and tooth location. Protocol of endodontic treatment. European Society of Endodontics, 1994. The first of all, it is X-ray examination before treatment. regardless of the diagnosis. Second, rinsing of the mouth with an antiseptic solution before treatment. Third, isolation of the surgical field by cofferdom. 4. Grinding of weakening bumps before starting treatment. 5. Sufficient opening of the tooth cavity. 6. Minimum extension of the root canal to files number 35. 7. Antiseptic treatment of the root canal with sodium hypochlorite. Measurement of the working length using X-ray examination and endodontic instrument and or apex locator. 9. Root canal filling. X-ray contrast with contrast material. 10. In case of apical periodontitis, obligatory filling with calcium-containing preparations for at least 1 week. If the presence of foci of destruction, about 3 to 6 months. Main stages of endodontic treatment by Nikolaev and Tsepov. The first, patient examination, diagnosis, endodontic treatment plan. Second, pain reliever. Third, isolation of teeth from saliva. 4. Opening the cavity of the tooth. 5. Detection and expansion of the mouth of root canal. 6. Passage of the root canal and determination of the working length. 7. Instrumental and drug treatment of the root canal. 8. Root canal filling. 9. X-ray quality control of root canal filling. And 10. Restoration of the crown of the tooth. Main stages of endodontic treatment by Lutskaya and Novak. The first, providing access to the root canal. Second, removing the contents of the root canal and preparing the root canal for filling. Third, filling the root canal with an inert material that guarantees reliable sealing. Stages of endodontic treatment by Nikolaev and Tsepov. Stage 3. Tooth isolation from saliva prevention. Ingestion of endodontic instruments. Getting the contents of the tooth cavity into the oral cavity. Entry of the contents of oral cavity into the cavity of the tooth. Stage 4. Opening the cavity of the tooth is carried out after creating access to the pulp chamber. That is the preparation of a carious cavity of trepanation the tooth crown. Take into account the anatomical features of the tooth axis, morphometric dimensions, localization of the carious cavity, age-related features. For A. Stage 4A. Preparation of a carious cavity or trepanation of tooth crown. Caries and poor filling are including the excess cavity. If caries is localized in the cervical region or the distal surface, then the cavity and the carious cavity are prepared separately. In this picture we see caries underfilling and tooth filling. Longitudinal section of the tooth. In this picture we see tooth enamel, caries, spread of caries deep into the tooth dentin and pulp chamber. Stage 4A. Formation of a burr hole. Primary access cavity. Corresponds to the shape and size of the pulp chamber. Provides free access to the tooth cavity and root canal. In picture we see primary cavity access, cavity tooth, and pulpal camera. The conventional contra-angle burr does not reach the orifice of the root canal, unlike the extended 5 mm surgical burr, or second name amputation burr. In this picture we see long burr and in this slide we see opening the cavity of the tooth. Design ideal access cavity for all teeth. In central incisor it is 1, lateral excisor 1, canine 2, premolar, first premolar 2, second premolar 1, first molar 3, second molar 3, and for third molar it is variable. Reference points for straight line access to the orifice of the root canals are: first, tubercle of the tooth; second, pulp horn. Third, orifice constriction. 4. Apex or point or curvature of the root canal. Access to the dental cavity. First, the place or opening the cavity of the tooth of the incisor or canine. Second, the initial direction of the drill during trepanation. Third, the direction of the drill at the second stage of trepanation. 4. Expansion of the entrance to the cavity of the tooth after its opening. 5. Optimal access to the root canal. 6. The endodontic instruments has reached the apical constriction. In this picture we see lower central incisor and how we treat this tooth. In the first picture we see shortening of the tooth crown and access to the root canal. Inclination of the tooth must be taken into account when access the cavity of the tooth. Stage 4, B and C. Opening and of the tooth cavity. Completely remove the roof of the pulp chamber. Create direct access to the orifice of the root canal. Remove all overhanging edges with the help of endobores, fissures, cylindrical bores, and conical bores. And we see in this picture that we must use non-aggressive endobore tip. In the left picture we see the cavity of the tooth is opened, the roof of the pulp chamber is partially removed, and the right picture we see created direct access to the root canals. First number, it is the roof of the pulp chamber, the vault of the tooth cavity. The second, the bottom of the tooth cavity. Third, the orifice of the root canals. In this picture we see overhanging edges of dentin, arch of the tooth cavity. In picture we see well-formed tooth cavity. In the left picture we see iatrogenic pulpitis, residual pulpitis, pulp not completely removed. In right picture we see in the frontal teeth, canopies, and pulp preserved but separated from the root canal. leads to pulpitis and discoloration of the root of the tooth. This happens uh, from 1 to 1.5 years after treatment, when the microbial decay of these residues penetrates into the dental tubulus. Undesigned access cavity. In picture A, preparation of the root canal through the carious cavity of class 3 according to Black. A sharp bend of the endodontic instrument contributes to the formation of a step, and then perforation of the root. Picture B. Small access cavity on the palatal surface of the crown. A sharp bend of the endodontic instrument with the formation of a step on the labial surface of root canal. Stage 5D, 4D. Amputation of the coronal pulp, removal of putrid masses with a spherical carbide bore. And in this slide we see stage 4D, amputation of coronal pulp, removal of putrid masses, but with an excavator. Stage 5. Finding and expanding the root canal orifice. By Angelet probe, bores may be used non-desirable. And in picture we see expansion of the orifice of the root canal. The first is endodontic instruments. The second picture it is gaze gliding. And third we finished the root treatment. Sixth, passing of the root canal and determining the working length. In picture we see apical part of a tooth. We see dentin, cement, anatomical apex, foramen physiologicum, and foramen apical, and X-ray apex. C. It is the X-ray apex, the most distant part of the root from the crown of the tooth on the radiograph. B. Anatomical apex, the place where the root canal exists to the surface of the tooth root. It is about 0.5 to 1 millimeters from the radiographic apex. A. Physiological apex, the border between the pulp and periodontal tissue. It is 0.5 to 1 millimeters from the anatomical apex. The apical construction is the area of the apical part of root canal with the smallest diameter by Ricucci and Langenland, 1998. In picture we see root canal, dentine, cement, physiological opening, apical construction, large apical foramen, and apex. Determining the working length. Working length, the distance from the physiological tip to any landmark on the tooth. The tip of the tubercle that cuts the edge of tooth. It is fixed on the endodontic instruments with a stopper. Weakened tooth walls should not be used as a guide, which can later be excised. It is better to carry out this excision immediately. Accurate measurement of working length requires constant monitoring of the strictly horizontal position of the stop marker on instrument. In left picture we see endodontic instrument with not horizontal position, it is the not right, and left it is the right. The stop marker in right position. Methods for determining the working length. The first, tabular, mathematical. Second, anatomical. Third, X-ray. 4. Electrometric. 5. Red dot method, paper point. 6. Tactical. 7. Based on subjective feelings of the patient. First, tabular, mathematical. We see table. In table we see upper and lower teeth and maximum, average and minimal. First incisor, maximum 27 and 5, average 25, minimal 22 and 0.5. 8 tooth, maximum 20 millimeters, average 80 millimeters, minimal 60. And you must know that upper and lower jaw have another mathematical number. Central incisor, maximum in lower jaw 23, in upper jaw 27.5, average 21, in upper jaw it is average 25, minimal 90, in upper jaw it is 22 and 5. In picture we see endodontic rule by Durov. The second, it is anatomical crown root as 1 to 2 or 1 to 2.5. In this picture we see X-ray method. The patient by fingers fixed the X-ray film, and the right picture we see that X-ray film image distortion, elongation of the apical part of the root on X-ray film. According to the X-ray image, it is read: the endodontic instrument did not penetrate to the apex. The working length is 1 mm shorter than the distance from the X-ray apex of tooth root to the crown point. In picture we see X-ray beam, X-ray snapshot, tooth with instruments in the canal. In the slide we see primary measurement, installation distance from apex to apical constriction, trial working length, final working length, and how we know about that, and measuring tool. And in this picture we see more completely the measuring tool. The X-ray method is not accurate even with the use of modern digital X-ray equipment, since the radiograph is a two-dimensional image and does not reproduce the entire anatomy of the apical part of root. Layers and image distortion are often noted. Discrepancy between the three-dimensional object and the two-dimensionality of its X-ray image. Electrometric method. The electrical resistance for direct current between the apical periodontium and the oral mucosa is the value of constanta, and between the oral mucosa and any part of the tooth it is much larger. By Sanada, 1962. In this picture we see the principle of the electrometric measurement of the position of apical foramen. We see endodontic instrument, alveolar ridge, apex locator, and lip electrode. Apex location method. Studies evaluating apex locator have shown the accuracy of determining the working length within 0.5 mm from the apical foramen in 75 to 93.4% of cases. The apex locator determines the length at the level of the foramen magnum, not the apical constriction. So 0.5 mm must be subtracted from the indication of apical constriction. The first apex locator, created in 1962 by Professor Sunada, determined the change in direct current resistance during the passage of the root canal. The readings of the first generation instruments were very unstable. The instrument polarized in the channel. The second generation apex locators used alternating current, but its frequency changed with the change in resistance as the tool moved along the channel, and the measurement results were also inaccurate. Starting from the third generation apex locator, determining the impedance of alternation currents of different frequencies. The impedance is lowest at the apical constriction and highest at the foramen magnum. In apex locators of the third generation, the absolute values of impedance were determined. These devices were sensitive to the presence of various electrolytes in the root canal and gave serious measurement errors. The fourth generation apex locator detect impedance differences. They are already less sensitive to the presence of irrigation solutions and biological fluids, but they require pre-calibration for accurate operation. Fifth generation apex locator determining the ratio of impedances. These devices allow you to accurately determine the working length in any environment without prior calibration. In this picture we see absolute impedance, impedance difference, and impedance ratio. And we see principle of operation of apex locator from third to fifth generation. An electrode attached the patient's lip closes an electric arch, the impulse from which is transferred to the monitor. The speed of the electrical impulse along the arch, from the tip of the file to the apical construction. Automatically calculates the working length. The principle of operation of apex locator is based on a sharp increase in current conductivity when the file approaches the narrowest part of the root canal. This is how the apical opening is detected. The apex locator creates a weak electrical circuit, and as soon as the endodontic instrument is inserted into the root canal, the current of the labial electrode increases and the microcircuit of the device independently regulates the current and calculates the distance to the apex. In picture we see apical construction and how apex locator based on if apex locator come to the apex, we low tone sound and numbers of the screen distance to the apex. When with apex locator we go to the apex, we intermediate sound, flash green light, see flash green light, the gates of the screen 0.0. If we behind to the apex, condition sound, see flashing red light and the gates on the screen 0.0. Apex locator and the east apex 02, and we see entrance to the apical zone, attained apex, exit to the periodontal, and apex locator and the east 3D. 3 mm to apex, 1 mm to apex, 0.5 mm to apex, and V in apex. Factors affecting the accuracy of apex location. loose fit of the mouthpiece to the oral mucosa, loose contact between the electrode and the instrument, excess fluid in the cavity of the tooth. There will be an electrical circuit at the level of the crown part of tooth. Incorrectly sized file in relation to the apical part of canal. If the tip of the file does not touch the walls of the canal, the readings will be inaccurate. With a discharged battery, the battery is less than 50%. Contact of the file with metal. A fragment of an instrument or a metal restoration leads to a circuit closure, and the location of the apex will be indicated inaccurately. The apex location method does not always work when the resorptional formalin is impregnated behind the apex. The resulting organic polymer is an insulator and or obstruction of the apical part. Since the electrical conductivity is disturbed and the electrical circuit does not close. 5. Red dot paper post method. 6. Tactical when an endodontical instrument is advanced into the root canal. It jams in the area of physiological narrowing. During the initial passage of the root canal, it is possible to determine the apical construction in 75% of cases, and 7 methods based on the subjective feeling of the patient. In the treatment of non-vital teeth, it is possible to monitor the patient's response to the advancement of the endodontic instrument in the root canal. Upon reaching the apical opening, the patient feels a prick. Determination of the working length by the red dot method. We see that we can know about length. Yes, it is the length to apex. It is the length about a periodontium. anthropometric method for determining the working length of the root canal. This length in millimeter by Castelli 1965. Central incisor upper jaw 25, lower jaw 21. Lateral incisor upper jaw 23, lower jaw 22. Canine upper jaw 27, lower jaw 26. First premolar upper jaw 21, lower jaw 22. Second premolar upper jaw 22, lower jaw 22. First molar upper jaw 22, lower jaw 22. Second molar upper jaw 21 and lower jaw 21. And third molar upper 18 and lower jaw 18 millimeters. Factors affecting the choice of working length. Diagnosis: the close location of the bottom of the maxillary sinus, the presence of an apical delta, absence of apex, resorption, resection, unformed apex. It is about children. Fragment of the instruments in apical third of the root canal. Thank you for all attention. This all for today. Goodbye.